Hello, and welcome to this year's EDS Hypermobility Patient and Provider Symposium. I'm so happy and honored to be able to host this symposium again. Thank you to all of NYIT and for all they do. And now today, when I was thinking about what I wanted to present, not only do we want to showcase all of our wonderful NYIT physicians, but I also wanted to show everyone what it was like to work in an osteopathic medical school and to show an example of a student who has been involved in the EDS Hypermobility Treatment Center and in the EDS research since the beginning and inception. So that's why today I have a former student. She actually just graduated this weekend from NYIT Dr. Winter Lesnick, with me, and she'll be doing the presentation with me. I still remember when Winter was a first-year medical student and came to me with an interest in research in hypermobility. We then went on and she applied for the student in-house grant as a first year, to which she received regarding her research with EDS and nutritional deficiencies, especially in vitamin deficiencies. Winter then went on as a second and third year and still had access to the clinic, went and rotated with us, got to see patients, and then in her fourth year, she applied for the EDS hypermobility elective, and she was with us for 4 weeks in the clinic where we were doing research. She then went on to receive the NISAMS Award and other very great awards for her work in EDS hypermobility. It's wonderful to see and now teach with Winter. We did the Florida Osteopathic Association in April, where we presented on our work in EDS and hypermobility. So this is a new thing this year. I wanted to show everybody, not only Winter's work and all she's done, but to also let the EDS hypermobile community know that here at NYIT we are not only educating the future physicians, but we're also educating these physicians to go out and treat hypermobile patients and for awareness of hypermobility. So Winter has been a wonderful student. It's been an honor learning from you and teaching with you and teaching you. And it's just such an honor to see her go on to her internal medicine residency. And I know that she's going to make us all proud. So let's get started. Today, we're going to speak about hypermobility unmasked, the subtypes and physical exam. So when we get patients, they always ask us, what is hypermobility? What is EDS? And what is the difference? So hopefully today with this lecture, we'll go through and we'll talk about each of the different subtypes, the subtypes of EDS, but also touch upon the HSDs as well. Every year we offer this patient and provider symposium. NYIT has a lot of publications. We've received some awards. We've applied for some centers. So we just recently, myself and Winter, did the Florida Osteopathic Academy. So we're really trying to take it national. I was recently featured in a Newsweek article. So we're really trying to increase our awareness on hypermobility and NYIT's clinic. We do believe in health advocacy, and with my work in all of the societies such as MISNI, NISAMS, and other medical societies, I always take with me some perils about teaching patients who have chronic illness or Ehlers-Danlos syndrome. And whenever I meet members of Congress or assembly people, I always talk to them about my experience as a director of the EDS Hypermobility Treatment Center. So we are aware, we really promote awareness, and we're really happy that we can do another patient and provider symposium. Now we're going to introduce Winter.
So thank you for Dr. Riley for that lovely introduction. Just a little about me. I just graduated, like she said, and I'm starting my residency in internal medicine at NYU Long Island this year. And I'm so excited to continue working with hypermobile patients and patients with EDS. I was able to start in the beginning with Dr. Riley. I was so lucky to have her as an incredible mentor my entire 4 years here, and she's given me invaluable opportunities just to work with the EDS Center and get exposed to research. So it's been really amazing. And I was able to complete an EDS elective in the hypermobile clinic at NYIT with Dr. Riley this past year. And it's been an incredible time. So I'm excited to be here with this presentation as well.
We're lucky to have you too, Winter, and it's great seeing you as a doctor. So let's get started. So what are the EDSs? They're still a group of heritable connective tissue diseases. We think they're caused by genetic changes. In fact, most of them do have the gene associated with them, but the most common type does not. And some of the features of EDS include
You can have skin elasticity, joint hypermobility. You can have tissue fragility,
and chronic
and
pain.
chronic pain.
So here we have the 13 different subtypes of EDSs. A rare 14th was found. That 14th type I have not ever seen, but they did find the gene for it. And I do want to talk about the classical-like EDS because I've seen an increase in frequency in that diagnosis. And at the 2017 International Criteria Guidelines, they did add that the TNXB one. So it is interesting to see the genetics and the changes throughout the years. There is a role for genetic testing in EDS, especially since there is the issue where you do want to make sure you're not missing one of the rarer types of EDSs or vascular EDS, which could have some serious complications. All EDSs do have comorbid conditions that are associated with it, but still the HEDS is a clinical diagnosis with a clinical checklist. So here's a list of some of the genetics behind it. It hasn't changed much since 2018. So now we're going to discuss a little bit about the HEDS.
Yeah, so the HEDS, the hypermobile EDS, this is the most common subtype of EDS, and in the clinic, it's what we see the most. It accounts for around 90% of EDS cases, and it's thought to affect at least 1 in 3,100 to 5,000 people, but there's not a lot of education around it, so the true prevalence may be underestimated. And this is a clinical diagnosis, like Dr. Riley said. There's no known gene associated with it. So you're going to have to make the diagnosis with the presence of criterion 1, criterion 2, and criterion 3.
And this may be why the diagnosis is hard to find physicians or providers who diagnose. We are a treatment center, so we don't diagnose here, but it is a challenging one to make in that it does have so many aspects. So we're now going to go through each of the aspects and we'll show you an example of some of the scores.
So criterion 1 goes on generalized joint hypermobility, and this is based off of Beighton's score, which is scored out of 9. And in order to meet the criteria, you have to get a certain number out of 9, but the score is gender and age specific.
And if we were to do a Beighton score, we always ask the patients to do it on themselves so we show the mechanism. Just remember that patients with EDS and hypermobile spectrum disorder oftentimes can be at risk, especially if they overextend themselves or are unstable. So that's why we have them do it themselves if we were doing it.
So to go through, me and Dr. Riley can do it with each other. So the first one is with the pinky finger, the 5th finger. So you're going to have your hand flat and try to lift your pinky. And if it goes past 90 degrees, that's a positive point. And so you're going to get 1 point if it's positive on the left and 1 point if it's positive on the right. The second aspect is for the thumb. So you're going to have your thumb pointed down and try to reach it back towards your forearm. I'm not as flexible as Dr. Riley, so she would get 1 point on the left and 1 point on the right because she can touch to her forearm. The third aspect is the elbow. So you're going to have your elbows outstretched, and we can use what's called a goniometer to help us with this, but you want to see if the arm extends above 10 degrees upwards. And then so it's positive on the left, it's 1 point, and positive on the right, it's 1 point. And then the fourth aspect is the knees. So you're going to you're just going to extend your knees. And then if the bottom aspect of your leg leans forward more than 10 degrees, that's a positive point on either side. And then the last aspect is the spine. So if you can bend down and touch the floor with both of your hands on the ground, that's a positive point.
So that's a total of 9, and that's why with the spinal flexion, it's 1 point. And that is a goniometer that you could use for the knees and the elbows.
So the Beighton score, like we were saying, it's out of 9, but it does take into account different changes with connective tissue with age and gender. So if you have a score greater than or equal to 6 out of 9 for prepubertal children and adolescents, greater than or equal to 5 out of 9 for pubertal men and women to age 50, and then greater than or equal to 4 out of 9 for men and women over the age of 50.
And so here at the EDS Center, we see patients 18 and up. And then let's say that they get the diagnosis of HEDS, they also have to fit into either criterion 1, 2, or 3. And one of them is always chronic pain. So with regards to the criteria 1, that's where you'd ask questions, because sometimes patients may have a past history of being flexible, but then let's say they had either injury or surgery or something that made them less flexible. So that's when you would ask, can you or did you ever? And those are those questions. And then with regards to criteria number 2, because these are all syndromes, we want to make sure that they are either systemic manifestation, they've had a first-degree relative with the HEDS as per the 27 criteria categories, and they also would have musculoskeletal complaints such as instability, chronic pain in 2 or more limbs, or other than that. Feature A is the tough one because it is so advanced, and there are 2 things that you would want to get an echo specifically because most echoes, what we're seeing now is they don't have the aortic root documented with a Z-score. So a lot of times people will have to ask the echo people who are reading it or the radiologist who's reading it for that specific Z-score if you are going to use this criteria to diagnose. But some of that criteria on this is used to make sure that you don't have other genetic disorders. For example, we've seen Lloyd-Dietz in patients who they maybe thought that they had EDS, and then they come back and they tested genetically for Lloyd-Dietz. And they may have things like a bifid uvula. They could have arachnodactyly, which I know we're going to go through, me and Winter. For one of the features of criteria 2, which we wanted to show you, are things such as the Steinberg sign and the wrist walker sign.
Yeah, so the Steinberg sign, that would be if you have your arm out and you put your thumb across, and if your thumb sticks out of the side, that's a positive Steinberg sign. And the wrist sign is if you're able to take your first and fifth finger around your wrist, and if they're able to touch or overlap, that's positive.
And these just show if you have very long fingers or things that could be morphinoid-like. In this picture too, they do show pyogenic papules, and those are bilateral. Those are when subcutaneous tissues are coming out of into the skin, and they form little papules on the bottom of the soles. They can only be seen when you're standing up straight, so with pressure. And then there are some atrophic scarring, and that's a picture that you do see. So I do want to caution you that if you see severe dermatological scarring, that should address you to maybe you don't want to miss something like a CL-EDS, the classical-like EDS, or classical, which oftentimes presents with very severe scarring or dermatological complaints. Criteria 2 and 2 feature B shows the first degree family history. So that's when you are going to have to ask the patient for some specifics regarding their family history. And then, which most of our patients have, is musculoskeletal pain in 2 or more limbs recurring daily for at least 3 months. And that, I should say, I think me and Winter would both agree, that is a major complaint of a lot of our patients, where they do have chronic widespread pain. Chronic pain is an issue in most of the EDSs. And this is the hard part of the diagnosis, which may be why some providers are hesitant to provide. You have to exclude alternative diagnoses. And it's so interesting through the years since I've been involved in 2018 in the EDS world. I've learned so many new disorders and new syndromes that also include hypermobility. For example, I've been dealing a lot with hypophosphatasia, which they're thinking even in their criteria, although one of them was always chronic pain, hypermobility has become one of their major symptoms. Like I said before, Lloyd-Dietz, Marfan's, other genetic conditions, Sickler's disease can also have the hypermobility component. So you want to make sure you're excluding these other diagnoses, many rheumatological. Not that you don't necessarily have a rheumatological condition and EDS. I have many patients who have both, but you just want to make sure that your alternative diagnosis is not limited to, and you're not missing a neurodegenerative disorder, a neuromuscular disorder, some kind of myopathy, or something else. I have seen EDS and OI. I have seen EDS and lupus. I've seen EDS and psoriatic arthritis and other things. But we've done research. We published a study regarding rheumatological manifestations in EDS, and it doesn't necessarily mean that you don't have it. It just means that do you want to explain that criteria too, that even if you do have a connective tissue disorder, you need to have an additional diagnostic criteria. Now we'll talk about EDSs, because I see patients who have EDS, but me and Winter have also seen a lot of patients with HSDs. So there's currently still the 4 HSD criteria categories. But what is HSD?
So HSD, it's a syndrome, it's very similar to EDS. It's a syndrome of ligamentous laxity resulting in recurrent joint pain and periodic joint effusion. And it has very similar overlapping features with EDS. It is a spectrum as well. So some patients can have very mild symptoms, some patients can have very serious symptoms, and it can affect different aspects of patients' life. So this is a diagnosis where it should be used for patients with symptomatic joint hypermobility when the criteria of HEDS has been ruled out. So you want to look at that criteria first and make sure the patient doesn't have HEDS, and then you can move forward to this. So it's kind of based off the diagnosis similar to EDS as well. You're going to have joint hypermobility using the Beighton score, and also one or more of the secondary musculoskeletal manifestations. There's 4 different subtypes. You can have generalized, which involves all the joints of the body; peripheral, which is just hands and feet joints; localized, which is just to one joint or one joint region; and then historical, where someone had a documented prior hypermobility that's decreased with increasing age.
And now we're going to talk about the clinical manifestations, because one thing me and Winter always saw was a lot of patients had comorbid conditions associated with EDS. And I know Winter, who has an interest in allergy, immunology, and other types of subspecialties, always had an interest, especially with regards to mast cell, which we'll talk about. But every system of the body can be affected by EDS. And for this, we're going to go from the top to the bottom. And sometimes you'll see comorbid conditions with other types of genetic disorders too. Like, for example, lens dislocation could be something that's seen in Marfan's. So those are also some things that the provider, if they did see in an EDS patient, should alert them. So in regards to the EDS, they could have blue sclera. And some of the rarer types of EDS, especially with OI or stuff, do present with blue sclera. So that is something you can see. And if you do, you'd want to make sure that you want to rule out some of the rarer types. We have a lot of patients who have dilated pupils. Sometimes we work closely with a neuro-ophthalmologist that people need a little further eval than just the regular ophthalmologist. We can see strabismus, ptosis or floppy eyelid, and we can see retinal tears and detachment. And again, these could also be seen in some rheumatologic disorders. So that's why it's so encompassing of all. That's why it's great to work with an ophthalmologist or have someone to know that collagen and connective tissue is part of everywhere in the body, and there are ocular manifestations of the EDSs. On my B. Riley at NYIT site, you can see we've published a paper with medical students showing the ocular manifestations of EDS. Then to go on to the ENT and oral manifestations, even in the category for the HEDS diagnosis, the high palate, narrow, sometimes dental, there's even a periodontal type of EDS. So you really want to check the dentition, the enamel of patients with EDS. Sometimes they can have onset of early periodontitis. We work closely with a dentist, but also oral surgeons and people people even have to have appliances because they find that either their mouth positioning or they have symptoms of a mild sleep apnea or sleep apnea, that they do need sleep appliances or have sleeping problems. And so there is these things that you could see not only in the oral cavity, but also in the HENT.
So to move on to some skin manifestations, you can have that skin hyperextensibility, a velvety skin texture. You can get striae, so stretch marks in areas that you don't typically get them. So Dr. Riley always tells me she looks at the back, because that's an area where you wouldn't usually see striae. You can get easy bruising, poor wound healing, and atrophic appearing scars as well.
And just a note on the hematologic manifestations, I have a theory that sometimes because EDS patients may have different kinds of collagen, I wonder if the what we're using to test may not fully show what is the exact. So, for example, I've seen patients who have platelet aggregation disorders or red zebras with bleeding dyscrasias, EDS, NOS, meaning not otherwise specified. And I'm wondering if when you see a simple CBC, it's totally normal, but yet they have a platelet disorder. So having a great hematologist or someone who's known in the field, and I'm hoping someday when Winter becomes a specialist, that's also a good field to go into, especially for the EDS population. And we are in connections and talk to hematology specialists and bleeding dyscrasias. So it is something that's new and coming, and something especially in my research that I look into. Urologic manifestations, we work with great urologists as well, because we do see urinary stress incontinence, vaginal prolapse, overactive bladder, diverticuli, and major pelvic floor problems. So that is something that especially the female EDS patients, but also male, can deal with.
So you can deal with a lot of psychological manifestations as well. Like Dr. Riley was saying, this diagnosis comes with a lot of chronic pain and fatigue, and it interferes with so many aspects of a patient's life. So you can see a lot of depression and anxiety, also some mood disorders. And Dr. Riley actually published a paper where she looked into that there were higher prevalence of language disorders and ADHD in patients with EDS and hypermobility.
Right. So working with neuropsychologists, psychiatrists, psychologists are really important too. Asking the patients a PHQ-2 or a PHQ-9 regarding depression screen, like any illness with chronic pain, there are adjustment disorders that can be associated. And I like to say to my EDS patients, I hope I give them hope. Right now, there is no cure, but we are a treatment center and there are treatment options. So we hope to do every system and go through it and try to help each of our patients in an individualized plan. So as you can see, there are a lot of comorbid conditions, not only associated with the EDSs, but also with the HSDs. And this is where we come into a lot of acronyms. That is very challenging. And since my work in EDS, I've had to learn a lot of new acronyms and new diseases. And some of these diseases require neurosurgical intervention, neurosurgical specialties, physiatry, which you'll hear later today, and things like AAI, atlantal axial instability, CCI, cranial cervical instability, Chiari, tethered cord. That's where you need to work with a great neurosurgeon, which we're lucky and blessed to have. And where you also see things like MALS. One of the reasons why I got my master's of science in clinical nutrition was in the beginning, especially in 2019, 2020 during COVID, 2021, is I was seeing a lot of eating disorders or eating disorder NOS or ARFID. And also I was seeing a lot of PEG tubes, J tubes, and I wanted to learn more about different formulas, different vitamin deficiencies, different nutritional things, and that really get down to the biochemical basis. And I know that's where me and Winter also have a real interest with regards to vitamin, nutritional. And what we've seen too is our patients a lot of times have difficulties not only with malnutrition or absorption, but also with taking things like supplements, medications. They may have allergies, which when we'll talk about the mast cell activation syndrome or disorder that you do see. So that's why if you can get your nutrients via nutrition enterally, that would be great, as opposed to doing supplements or medications. If which may have even their coding you have to think about, because you'd be shocked how many supplements have gluten in the coding or other things like sulfa. So please look at inserts, packets, inserts for anything that you're taking over the counter, especially if it's not FDA approved.
So the mast cell activation disorder, the relationship is poorly understood. It's not really known why this is seen so much with patients with hypermobility and EDS, but it may be explained through persistent chronic inflammation contributing to disruption of the connective tissue. And the aberrant mast cell activation can disrupt connective tissue integrity further through the activity of mediators like histamine and tryptase. And we actually were able to go to a talk with an allergist, and he was saying the best way to see if a patient does have mast cell activation disorder is to take a tongue depressor and brush it across their skin. And if you see a reaction and like big, like reddened area, that's a key indicator that it could be mast cell activation. Because if that's just occurring on the skin, imagine what's occurring inside the body.
Yes. So, and what Winter's referring to is every month, as the EDX director, ask a different specialist or a combination or some either rheumatologist. Last month was an allergy immunologist, a great one, geneticist, or sometimes we have medical device companies come in, and we talk about, have a collaborative approach for EDS. And monthly we have our EDS committee with all members of the EDS committee and all specialty members, where they get not only access to the different types of specialists who come to us and speak on what they see, but also research ideas and collaborations. For example, recently we had a physiatrist come and speak on even what he's noticed with regards to ferritin levels and iron. So it's really interesting, and also allows for a lot of collaboration and a lot of discussion, not only with the students who come and get invited, which we're thrilled to have, and Winter's been at many of them, and even today, you'll be at today's one with a rheumatologist, but also to see all the specialists to talk about clinical cases and clinical care. And this mast cell activation disorder is something that we were excited about, finding someone who does diagnose it, and also realizes the connection with EDSs, hypermobilities, and mast cell. POTS dysautonomia, you'll be hearing from Dr. Todd Cohen, our EP physician and distinguished professor at NYIT just became distinguished professor, so I definitely wanted to give him that plug. On POTS, he's our EP physician who diagnoses POTS with the tilt table test. And this is a very common diagnosis, especially in the EDS community. And that's why a lot of people, they either on their digital health, whether it be an Apple or an Android watch, they'll notice that all of a sudden their heart rate's increasing just by standing up from a seated position. And this can cause not only cardiac symptoms, but also can cause real issues to the heart. So we did a study at the NYIT Center with Dr. Todd Cohen's group with all of his medical students as well, that showed that almost 98% of the EDS patients that we share do have cardiac complaints. Chiari malformation is something that we do see with regards to the neurosurgical issues. And this is when there's a downward displacement of the cerebellar tonsils through the foramen magnum. And that's when you really want to get a good neurosurgeon connection to see these, and also specific testing for it.
So you can also see tethered cord syndrome, and like Dr. Riley was saying, this is when you want to get like a neurosurgeon or a specialist involved, and that's just, it results from restricted movement of the spinal cord. So the caudal end will have a fibrous tissue attached, but in healthy individuals, usually it acts as a buffer, but in individuals with connective tissue disorders, it can become very rigid. And then these patients deal with a lot of pain associated with that.
Yes, and a lot of times they could have urological manifestations too, which is why we're blessed also to have such great connections with urologists. But like Winter said, it is something that you do need a multidisciplinary team to get. There is treatment, and we like to say we don't just do a one-stop shop. We like to say treatment is individualized to every patient. We try to ask for the top 3 complaints at our first initial visit and make sure that we address them at that one visit. Some of the things I see a lot is chronic pain, and you're going to hear from our physiatrist regarding that. But there are different types of pain medications, physical therapy, occupational therapy. You're going to hear from our director of rehab services. So you're going to see all these different availabilities of treatment options at our NYT center. But there also is CBT. Some people need DBT, psychotherapy. Some people need biofeedback. If there's a component of rectal prolapse, constipation, you need to have a multidisciplinary approach. You need to have great team members who not only are very well versed and educated in the field, but also have an interest in seeing patients with EDS. There are some pharmacotherapy, but again, you always have to be careful for allergies or side effects of the medications. And that's when we give a lot of patient education, which is what I try to do every year by organizing and moderating the EDS Patient and Provider Symposium. I try to have this as an advocacy not only for the patients, but also for providers who are interested in EDS. I encourage anyone who wants to reach out to me and talk to me if they want to be part of our committee meeting. I try to host it every month. You could be either online or in person, because we are nationally known. So we can work with people from different states. So if you do want to participate or help with regards to lifestyle modifications, health advocacy, EDS help, or if you want to just be an access or introduced to our team or have them know, please reach out to me, because I do try to hold these sessions for providers as well, many of whom I get emails on a daily basis from patients who are desperate for help, and I get emails on a weekly basis from providers who need help sending patients to physicians like ourselves or like what we have here at the center who want to see. So this is a growing disease. The prevalence has increased, and it's a challenging disease to treat because they do require individualized care. And me and Winter are really for the nutrition aspects. So now we'd like to showcase what we did and talk about that.
So we were able to create a project around nutritional deficiencies and EDS patients. And this all started because Dr. Riley shared an article with me where it understood that a lot of the vitamin deficiencies you see and the symptoms associated with them can also be seen overlapping with EDS, like the skin hyperextensibility and the poor wound healing and even some fatigue. So we were able to investigate a bunch of the known research on vitamin deficiencies and try to figure out, are there known deficiencies that maybe people are unaware about? And we were able to find there is a known deficiency, at least in the papers we were able to review, of vitamin D and calcium, but there were a lot of other vitamins that weren't as researched. Like we were kind of curious about vitamin B12 and vitamin B2. There's not much research out there about that. So that's one thing that Dr. Riley has definitely instilled in me, that I want to continue on to research, because vitamins play such a crucial role in so many symptoms that these patients might be dealing with.
Yes, and me and Dr. Lesnick will have a lifelong connection. So hopefully she'll be part of all of our research studies, especially with regards to this. But one thing that is challenging, which we always talk about, is sometimes the serum levels do not reflect the exact amount that your body has. So it's such an interesting thing on a biochemical basis. Also, many of the labs that you need, for example, if you need a vitamin B6 drawn, it's challenging to get the lab because it needs to be covered in aluminum and it's light sensitive. So even things like the laboratory values, you have to really research. And we did do this systematic review, which we hope to get published. We have so many ideas. So now that Winter's a doctor and in July she starts her new residency, I know she'll be busy as an intern, but I look forward to doing more studies with you. And the biggest thing that we hope is prevention. And this is for all patients, but especially patients who have EDS and hypermobility spectrum. As a primary care physician, what I always say is, in addition to the EDS or to the HSDs, you also have to take care of yourself. There are many vaccines that you need. There are many preventative measures such as pap smears, mammos, bone densities, depending on age, U.S. Task Force recommendations. They are constantly updating the vaccine schedule. So really preventative care is important as well. And it's important to not only remember that you have to take care of yourself as well as yourself with the disease. And so just something that we always end with, Winter.
Yeah. So I like to end with this just because we're always taught to like, don't look for the zebras in medical school. Look for, it's probably the most common thing that you're thinking, but this is just a reminder not to forget the zebras because this rare disease is increasing in prevalence and it is seen, and patients might be suffering with it and they have no idea. So it is important just to not miss this diagnosis.
And I hope you realize how amazing and lucky we were at NYITCOM, especially me, to have one of the students, and this is a perfect example, who have followed through the EDS hypermobility spectrum world with me from first year, second year, third year, fourth year, showed an interest right from day one, and we've been so lucky to have Dr. Lesnick with us, and it's going to continue on. So it just brings me such pleasure to be able to teach the new and future physicians and to see such a success story like Dr. Lesnick. And thank you all for listening to us. We've gotten a lot of references here, many of which are from our NYIT Center. We're constantly looking for research. We're looking for donors. We're looking for objective findings for EDS. We have a lot on our agendas every month with our EDS committee, and we just wanted to give you a snapshot with what we do on my other side, being a professor at NYITCOM in teaching the medical students. So thank you again for joining us, and we look forward to our other lectures. Dr. Andrea Coladner graduated from NYITCOM in 1990. Following her 4-year residency at Mount Sinai in physical medicine and rehab, she became the medical director of Long Island's first traumatic brain injury unit at Southside Hospital. In March of 1996, Dr. Coladner then opened up her private practice in pain management, which she was in for 23 years. In 2019, she joined us here at NYITCOM, and we've been lucky to have her ever since. She's working as an assistant professor in the Department of Family Medicine, and in her current position, she also sees patients in the Central Islip location, as well as serving as the associate medical director of all of the clinics here. She provides the students with on-demand lectures on musculoskeletal topics, eating disorders, and substance use disorders. She's been an active part of our EDS clinic, and we're so lucky to have her speak again this year. It's my pleasure to introduce Dr. Andrea Coladner.
Hi, everybody. This is Dr. Coladner. Today, we're going to talk a little bit about musculoskeletal pain in Ehlers-Danlos syndrome. I'm a board-certified physician in physical medicine and rehabilitation, and I see a lot of patients with chronic pain. And in our clinic in Westbury, I see a lot of patients with EDS and chronic pain. So we're going to talk a little bit about that today. Our agenda is very simple. Basically, we want to know why you have the pain that you do, and more importantly, what can we do for the pain that you do have. So there's a lot of reasons that Ehlers-Danlos creates pain. I see patients that have a diffuse amount of pain, global in nature, meaning that it's kind of all over the place. Some days it's your hand that's hurting, some days it's your left knee, other days it's your spine. And the difficulty in treating this kind of pain is that, first of all, it's all over the place. And second of all, it tends to come and go. So there's no one, I hurt my shoulder, I had surgery on my shoulder, now I'm going to rehab my shoulder. That's not what we usually see in patients with EDS. It's more of a pain that comes and goes and moves around. And that makes it a little more difficult to treat. So the first type of pain that we see is called nociceptive pain. So that's nociceptive, nociceptive pain. And basically what that means is that the pain is coming from an area that has pain fibers and so is generating pain. So why do you get pain in Ehlers-Danlos? In the joint, the pain can develop from the hypermobility that many of you experience. There's too much movement, and that movement leads to a more rapid degeneration and can promote inflammation in that joint space. And that, of course, creates pain. So the hypermobility and the excessive movement that can occur often leads to abnormal bone and cartilage formation, which is then in the joint. So anything that moves around that abnormal bone or that abnormal cartilage is going to be painful. So the tendon that runs over the joint space, the ligament that can run over the joint space, will become inflamed from that excessive abnormal bony growth. The tendons and the ligaments, in addition, can not only be painful from that, they can also be painful from the laxity and the sagging that occurs from overstretching the ligaments and overstretching the tendons. So you can see from the picture that the tendon is the edge of the muscle. So the muscle leads to the tendon, and the ligament connects bone to bone. And if there's too much movement in the joint space, then there's excessive amount of stress and stretch on the ligaments and on the tendon. And that excessive movement, that excessive stress, and that excessive stretching will create an inflammatory reaction, create laxity and sagging. And all of those factors will contribute to pain. You also have ineffective mechanical forces, meaning that the muscle and the tendon are trying to work against an object that should be strong and stable and sturdy, but isn't. It's too mobile. So the tendons and the muscle and the ligament all respond to that abnormally loose joint space. So the muscles can't function properly when the tendon is so stressed out. And then you also develop weakness. And weakness develops because of two different things. One, because again, the hypermobility causes stretching of the tendon and therefore the muscle. But also because of the pain, a lot of folks stop using the joints, which means that the muscle itself is going to shrink in size and atrophy. The muscle strength is your last bastion of hope to tighten this joint. So if you leave with one thing today after listening to this talk, remember that you have to move, you have to use your muscles, even though it's painful, and I know it's painful. But we can't strengthen the joint. We can't strengthen the ligament. But we can strengthen the muscle and the tendon. And therefore, we have to do our best to maintain strength in the muscle. So where else can pain come from? Pain can be nerve generated. In this particular case, if you think about what we talked about before, the hypertrophic bone and cartilage forming around the nerve can irritate the nerve itself, creating nerve pain. And the hypermobility stretches the nerve beyond what it's used to and comfortable, and that can also create nerve pain. So it can be caused either by compression, or it can be caused by osteophytes pressing on it, or from the inflammatory cells from the hypermobility. Nerve pain feels different than nociceptive pain. It can sometimes feel like pins and needles or burning. Sometimes you can get numbness. The biggest problem with nerve compression from any cause is that it will hasten weakness in the muscles that it innervates. So in this particular case, median nerve innervates the muscles of the hand here. If the median nerve is compressed, it can weaken the muscles of the hand. There's a third type of pain, and this is called nociplastic pain. This is kind of a new nomenclature in the field of pain. It's taken the place of what we used to call central sensitization. And basically, this pain results from alteration of the body's normal pain sensing mechanism. So the brain is perceiving what should be normal touch as painful touch. It's something that we have seen originally and discussed originally in patients that have fibromyalgia, but we see it now in most patients that suffer from chronic pain. So the pain signal is just being misinterpreted by the brain. Then I know also a lot of folks complain about GI pain. I'm not going to go into that because it's not what I do. But if you have GI pain, obviously, you should be seeing a gastroenterologist for that. So what do we do to treat all this pain? There has to be a multidisciplinary approach that includes physical therapy, bracing, equipment that will help you spare your joints to make your activities of daily living a little easier. There are some medications we use, and we often use cognitive behavioral therapy as well. Pretty much anything that incorporates movement will be helpful for your pain. So I'm sure many of you have been in physical therapy, exercise-based treatments. It's usually combines some type of stretching and strengthening, stabilization of your core. What we like to focus on is functional activities. So going through movements that mimic things that you will normally do. Lift up a grocery bag out of your car, or bend over to make your bed, go up and down stairs, things like that. So we like to incorporate functional activity into physical therapy. But remember that physical therapy, if you go regularly, even if you go 3 days a week, it's only 3 hours of your week. You really need to focus on doing strengthening activities and maintaining your strength throughout your entire day, not just for the 1 or 2 or 3 hours of physical therapy that you go to every week. So devices can be helpful. That can be a decision that you make with your provider or that you make with your therapist. They can provide support. They can help reduce pain for sure. The biggest downside, and the reason that I don't really like bracing, is because if it's used on a regular basis, it will actually promote more weakness, and that's something that you absolutely don't need. So I use braces very, very sparingly, and when I do use them, I try to warn folks that, this is not something that you should be using every day. It's not something that you should be wearing 8 to 10 hours a day, because it's just going to make that area weak. It's something that you can use on an occasional basis if pain is just out of control and you're kind of at your wit's ends and don't know what to do. That's when you can put a brace on if it helps you. So cognitive behavioral therapy is not a new therapy, but it certainly has gained in popularity in the last 10 years or so. There are studies that have shown the efficacy of cognitive behavioral therapy. It can help with not only anxiety and depression, which tend to sometimes go along with chronic pain, but also help you actually cope with the chronic pain. There are some medications that I do prescribe, anti-inflammatories. You can take something over the counter, you know, a Motrin or an Advil or naproxen, anything like that. If it helps you and you don't have any kind of bad reaction to it, you can take that. Muscle relaxants, I'm not a terribly big fan, but some folks take them before bed because they make you a little drowsy and they do help some people sleep. But I'm not a big fan of taking those during the day. I do use a good deal of low-dose naltrexone. If you're not familiar with it, you can certainly look it up. There are a couple of really good studies out there that show it has been efficacious in chronic pain with minimal side effects. And then we also use antidepressants to help manage pain. Not just for the antidepressant effect, because honestly, when we use them for pain, we use much lower doses than what's called for in depression. But specifically the tricyclic antidepressants and the serotonin reuptake inhibitors have been shown to be effective in helping chronic pain patients manage their pain. So for me, the key to success is individualizing your pain management for you based on your likes and dislikes, based on the severity of the pain, based on your energy level. Things like yoga, meditation, Tai Chi, all movement-oriented activities that will help you. Floating, it can be very helpful. I always put gardening in because I think it's very therapeutic to grow things and then eat them. Dietary considerations, I spoke about that last year. That was my whole talk last year, was what to eat and what not to eat. So you can look into foods that promote inflammation versus foods that are anti-inflammatory in nature. Stress reduction is a big part of managing chronic pain, and having a sense of purpose and a sense of belonging. We all need that, whether you have chronic pain or not. We all need a sense of purpose and belonging. So join a club, volunteer an hour a week somewhere where you're needed. I think it will prove itself to be very worthwhile endeavor. So that's all I have for today. I hope maybe one or two things resonate with each of you and help you on your journey to a better quality of life. Thank you.
Dr. Jack Comeau, our Director of Rehab Services at NYIT-COM, got his doctorate in PT at Stony Brook University. He then went back to Stony Brook to get his Albert dissertation in his PhD in physical therapy. He focuses on Pilates-based rehabilitation of the lumbar pelvic instability. He has been a part of the EDS Hypermobility Treatment Center since its inception and helps to treat many of the patients. We're so honored to have Dr. Comeau speak again this year.
Hi, I'm Dr. Jack Comeau, physical therapist and supervisor of rehabilitation at the New York Institute of Technology College of Medicine Academic Healthcare Center. I'm happy to take part in the 2025 EDS Symposium and talk to you a little bit about my experience with treating patients with hypermobility spectrum disorder or hypermobile EDS. I have 20 years of experience as a clinical physical therapist, and over the past 7 years since I joined the team here with Dr. Bernadette Riley, So for the past 7 years, I've been treating patients, a lot of patients with hypermobility spectrum disorder or hypermobile EDS. Currently, about 25% of my patients fall into that category. So it's definitely grown consistently over the past 7 years in the practice, and we continue to develop our approach and try to deliver quality service to this population. Here we see on this slide the components of the Beighton score. The general flexibility in the joints that can lead to microtrauma over time, causing damage and leading to recurrent painful conditions in the joints, functional impairments and limitations in activity and lifestyle. Most patients come in with a goal of improving their lifestyle, improving their quality of life, reducing their pain, improving their function. And that's what we're here to help them to do. We have a broad spectrum of patients with the similar diagnosis that don't necessarily present the same. Some are severely impaired, some have minor impairments, all of which are important to the patient. And as providers, we want to see you be successful. Your success is our success. There's certainly comorbidities with this population that need to be identified and prioritized. And we'll talk a little bit more about that. There is often some commonality in the histories given by patients with hypermobility. One of the commonalities is in their youth, in their youthful days, in their childhood days, they were very active. They participated in things like dance and gymnastics and sports. And they were quite often retrospectively, they'll look back and see how many sprains they had over the years that led to this degeneration of the joints and the destructive properties that lead to their current functional limitations. For providers out there, when you're taking a history and you hear about this background of sports, you think you have an athlete on your hands, which you may very well have an athlete. But patients with hypermobility, when they're symptomatic and reactive to activities, we have to approach them differently than we would your common sports athlete. They may be more reactive, more likely they're going to be more reactive, and you just can't assume the same progression. Patients with hypermobility need to be taught a varied sequence of activities like therapeutic interventions for exercise modalities, and so they can modify it down or modify it up depending on what kind of week or month or day they're having. Because often there's fluctuations in their function based on how much inflammation's in their body and other comorbidities that may be affecting their overall function. In their histories also, you may see failed surgeries, and they may be presenting with impaired proprioception because of all the microtrauma to their body over the years with these recurrent sprains and strains. So that's something else that we need to look at is, well, what exercises will regenerate proper proprioception and develop improved proprioception so that we can stop adding microtrauma to the body. So finding that mind-body connection and some mindful practice of movement and exercise that will help to achieve that. Many major hospital systems utilize a person-centered model of care. And embracing a model like this will help a provider evaluate a patient for all the facets of their life, everything that's involved. Taking a holistic approach to finding all the barriers, obstacles, benefits, pros and cons to everything about the patient that presents in front of you. What are their goals? Are the goals realistic? And how can you meet halfway or make some realistic goals, some tangible goals? Providers need objective goals and patients need quality of life, which is quite often subjective. We need to find a way to meet in the middle and identify simple things like a 6-minute walk test or some objective measure that might carry over to improving quality of life. And it will give us the clinical ability to mark our success, because we need to know if what we're doing is having a significant impact on your life, reducing your functional impairments, improving your ability to participate in the community, things that really matter. On this slide, we see the components of the International Classification of Function, which was a framework designed by the World Health Organization to help establish some framework to go by for establishing functional goals, community participation, and also identifies comorbidities and barriers and contextual factors that might have an impact on patients' outcome with care. So it's good to use these tools, this model and framework, when you're working with your patients, when you do your evaluation. It makes sure that you take a holistic perspective on the patient and establish some specific goals, some customized goals for the patient in front of you. As providers, we all like to have protocols and templates to go by, but at the end of the day, we have to adjust them and customize them to the patient in front of us and make sure we're meeting their needs as best we can. Patient and provider alliance, it's undoubtedly a team effort. Usually when I evaluate a patient, we first meet, the purpose of the evaluation for a provider is really to examine a patient, identify impairments, identify functional issues, but on top of that, and create a problem list and some goals to address the problems and these things that we do in our notes and our plan of care. But overall, it's also a time for a provider and patient to meet and discuss, well, as a provider, I have a certain set of skills, and as a patient, you have a certain set of needs. Do my skills match your needs? And are we a good match? Is there the potential for you to benefit from a plan of care with a provider like myself? It's a chance for us to discuss that and sometimes meet in the middle. At some point with patients, I might even reach a point where there's a plateau. I feel like maybe their benefits have stopped. And if ever that happens, I'm always welcome to expanding to other professionals, seeking out new providers who can perhaps offer more, offer a different set of skills, different set of treatments. And then it's a constant, ongoing, developing relationship, just like any relationship in life. It's a two-way street, and there has to be open communication with what works, what doesn't work, what patients are doing outside of the clinic that may be contributing or causing flare-ups that we're not aware of. So as a provider, I may spend an hour or two a week with a patient when they're on program, sometimes longer, sometimes less. It's not a lot of time to get a grasp on everything that a patient does 7 days a week, 24 hours a day, right? So that communication and that team effort is really important. Tracking your activity through apps like Bearable or smartphone trackers, anything you could do to bring us tangible data is helpful. As providers, as healthcare experts, we like tangible data. We want to really be able to measure success when we can. Of course, overall, the measure of success is patients' ability to engage in their life and have a successful and fruitful life. So often the term complicated comes into play, often when discussing patients with Ehlers-Danlos syndrome. I think being complicated has a negative connotation to it. But when people have multiple comorbidities, it is complicated. It's generally complicated because there's a lot of things you need to consider. What are the impacts of cardiac issues, gastric health issues, mental health issues, sleep hygiene habits. All these things need to be addressed uh, at least topically in an evaluation, especially the big ones like cardiac issues. Providers need to know how hard they can press someone, what intensity they can exercise at. So cardiac issues are the first thing to clear. Perhaps equally or more impactful are gastric issues. Prioritizing the health issues is one of the most important things we could do as a team. Discussing what the issues are, keeping those issues out on the table in discussion. Dealing with constipation. If someone is constipated, they haven't had a bowel movement in 3 to 4 days, well, their exercise capacity is going to be diminished. Their overall vibrance and health is going to be diminished. These issues like that, gastric issues like that, really take a priority. And then as a team, we need to decide, well, what are we going to do with you while you're in that period? Are you in a recovery period? Are we in a period where we can push the envelope, try to make you stronger? Or do we need to do more mobility exercises, general functional exercises, keep you moving, perhaps give you some corrective or prescriptive exercises to maybe help with the gastric mobility when possible, if possible. So prioritizing and identifying any of these comorbidities to reduce the complexity, reduce that complicating factors is so important. So we can keep coming down to the basics, simple things that will make you stronger. So an evaluation in physical therapy has many components. We'll look at many different systems. Often, if someone has multiple issues, a vestibular issue, meaning balance problems, proprioceptive issues, musculoskeletal issues, multiple joint pain syndromes. It's a lot to be able to evaluate in one session. So we may tend to prioritize and pick and choose and evaluate over a course of sessions. One of the things I like to know, always we have a chief complaint, is that I can't do something, because that's the nature of our business in rehabilitation. For establishing goals and establishing what can be done, we need to know what you can do, establish what you can do. And I mean that on a functional level. How does your body feel when you're laying on your back, laying on your stomach, laying on your side, kneeling, half kneeling, crawling, sitting, standing, walking? Functional evaluation of your tolerance for all these activities gives us a window to what type of therapeutic interventions or exercise interventions can be performed. So during an evaluation, when we identify those things, it helps us, right? It helps us to have a plan to intervene, a plan to make changes in your body for the better. The biomechanical approach, in all of these positions, we're looking at posture, your ability to breathe. We'll look specifically at strength in the joints, in different muscle systems, range of motion, flexibility. Now, usually range of motion may be excessive in many of the joints, specifically like the shoulders, the knees. Flexibility, there's this myth that people with hypermobility shouldn't stretch. It depends. Everything in life, and especially in rehabilitation, depends. They may, just like many other people, different populations with chronic impairments, they'll develop imbalances in muscle function, meaning some muscles might become short and tight, some may become long and weak. We need to address those muscle imbalances. There's other things about a neurological approach regarding muscle synergies. So muscle synergy is like a muscular habit, how things tend to move together in certain muscle groups. So muscle synergies can often be rehabilitated and changed. We use the term neuromuscular reeducation, where we can re-educate how your muscles are firing and in what groups to provide different types of stability for different joints in the body. And the mind-body connection, trying to establish a safe space in the clinic for you to learn to move and be confident with your movement should overall help you make functional gains and improve your life and your body's ability to move, and engage in a mindful movement practice. My background incorporates a little bit of martial arts, a little bit of Pilates, a little bit of yoga, a little bit of calisthenics, and we kind of modify and try to customize a program that's specific to you and would benefit. Now, a lot of these things are generic forms of exercise, just basic exercises, but it's always not what you do, but how you do it. It's really how you do it that's important, and understanding how to make things a little easier. How do I do a certain exercise and take a little pressure off my lower back? Or how do I do an upper extremity exercise, like an arm exercise, without overstretching my shoulder? So there may be generic exercises, meaning they're just common exercises, but there's subtle things you can do to change them, to be more mindful of your posture, using your breathing during an exercise, and in certain cases, limiting your range of motion to a safer zone where there's less biomechanical stress on the joints, less shear, less torque. Sometimes we want less compression as well. So these are all the biomechanical factors that affect how we move and also how we perform therapeutic exercises. One common complaint that I hear is that as a patient would state, I don't know where my body is in space, or I'm clumsy, or I don't move well in a manner that they may hurt themselves, right? So there's a lack of confidence. So in effect, that may be a kinesiophobia. There's a fear of movement there, lack of confidence in their ability to move and control their bodies. There's limited research available to really identify a strong template to approach at this time. This one study used Pilates-based exercises, and in no way am I endorsing just a general Pilates-based exercises. If you open a generic Pilates mat work book and look at the routines in there, many of the exercises would not be good for someone with hypermobility, especially hypermobility of the spine, the neck, the shoulder. So I would be extremely cautious with just exploring yoga, Pilates, martial arts on your own without consulting a therapist or an expert in kinesiology at the very least. So be cautious with just that self-exploration. I would bring exercises to a therapist and say, what do you think about me doing this? What do you think about this regimen? And then we could look at it together and we could modify it as needed, or just straight out avoid it if that's the case. Some people have certain hypermobility that they should avoid certain postures, right? And I won't get into specifics there, but there's we'll customize things for you to help you engage in that mindful practice. Now, for the past year or two, I've seen more young people with hypermobility disorders using wheelchairs. I'll be the first to admit that there's always trends in healthcare and trends in fitness. This is a trend in mobility that it's somewhat confusing for providers. When we see a person in a wheelchair, generally we think that someone's not a candidate to ambulate, or they're so severely limited that they need the chair. So be cautious with, as a provider, with judgment. If someone comes in a wheelchair and then they can ambulate, and you're thinking like, well, they should walk around the room for 2 minutes, then why are they in a wheelchair? You start to go and start thinking of different tracks. So don't judge. If they start working with physical therapists and they work on their gait ability, their ability to walk, and their duration, it may be that they have a tolerance of walking 20 minutes a day, and once they hit that number, they flare up. They flare up in pain that just impairs them for days, right? So by utilizing a wheelchair or any other assistive device, it may enhance your ability to have a more functional day throughout the whole day. But sometimes these things are a little confusing. believe there's a dance troupe called the Rolettes, and I saw a Rolettes video more recently during the past year, and it's pretty impressive, you know. But as a physical therapist, it is somewhat confusing. I see some people stand up out of their wheelchair and do a dance move that makes you think they're more capable, but the fact may be that they can't keep doing that dance move. They just only had the one or two, and then they need to sit it out, you know. So trying to be open-minded with the use of wheelchairs or any assistive devices that make your life more rich. Now, it is very common that a patient with hypermobility will come to a therapist's door, to their clinic, and have a history of failure with other therapists for a variety of reasons. It's very important to take the time to detail that and find out the reasons, so they can be avoided again in the future. I think one of the main reasons for failure is not identifying triggers, and there may be a delayed fuse on a trigger as well. Someone develops pain on a Wednesday, but it was due to what they did on the previous Saturday. And sometimes you can't always put that together too quickly. So a lot of conversation there needs to be had, or a lot of activity tracking. So the more journaling you do as a patient, the better off we're going to be, more successful in identifying your triggers and avoiding them. Establish a response to care prior to progressing. Therapists have limited time with patients for a lot of different reasons. One is just business models and practices. Another one is insurance-based rehab. We may have limited time with the patient, so we need to try to do as much as possible in a short period of time. However, we have to establish a response before progressing. And if I'm seeing someone with a 2-day gap, I see someone on Monday and then I see them on a Wednesday, and I say, oh, they handled everything on Monday very well, I'm going to advance on Wednesday. That's not always the best step, because inflammation may have not set in from what we did on Monday. So you may add different low impact. Just be careful with how much impact you put on the joints and how fast you progress with shear, with stress, with torque, tension, strain. As far as range of motion, same, establishing a safe zone in range of motion. Practicing movement and helping patients identify where their joints are. What is their range of motion? How do they connect? Specifically the shoulder. The shoulder is very easy to stress the glenohumeral joint, or where the socket of the arm into the shoulder blade, and not move the whole shoulder girdle. So I think it's important for people to learn their scapular mobility. And what does that mean? What does it feel like, as opposed to just upper extremity mobility, which may include hypermobility of the glenohumeral joint. So the shoulder is specifically predisposed to hypermobility or excessive range of motion, depending on the type of movements you're trying to achieve. So a lot of education there, visual feedback, knowledge of performance, knowledge of results, augmented feedback to give people, to help strengthen their body-mind connection. So insurance-based rehabilitation, it's a rapidly changing environment, so it's been changing for the past 20 years. Things change. What's changed the most is more people have less coverage. It's been the general theme. So it puts more pressure on a provider. Instead of doing research-based protocols, such as training 3 times a week for 12 weeks in a certain progression of activities, I might have a patient only 1 time a week for 6 weeks. And then we have to decide, well, how do I make most use of that time? What could possibly be taught to a patient in that short period of time? And how do I prioritize what we want to teach them and have them learn, be able to demonstrate that they've learned it? So the burden to the provider is they have to be more concise with their education and more precise with what they choose to rehabilitate, because they may not have enough time to do everything they want. And then the burden is put on the patient to be consistent, to document on your own what you're doing, to do journaling, and to show that you're doing what you've been instructed to do. As a provider, it's pretty easy for me to determine whether or not a patient has been doing their homework, so to speak. I could ask a patient to come in and say, show me your exercise program. And I'm not going to say a word. I just want you to see you go through it. Show me what you've been doing on your own. And that is a great test. And it's not to catch a patient. It's really just to make sure that we're on the same page with communication, because our success is based on what we do together, and a provider fulfilling their part of the bargain and a patient showing up and doing their work as well. When a patient comes in with multiple comorbidities, it is easy to fail. And I don't like to fail. I think most professionals don't like to fail. Healthcare providers don't like to fail. They don't like to see people suffer. Most healthcare providers get into the profession to help people, right? We want to see people better their lives. Plan of care is, the science of the plan of care is the frequency in which someone comes in. How often do they train? The intensity and the duration. So how often do they train? What do they do while they're training? That's the intensity of how much work they're accomplishing and how much time. And how many weeks or months are they going to be doing this? So patients who are complicated by multiple comorbidities have issues. They have other issues that come up. They have a flare in gastritis. They have several days of constipation or diarrhea or some other health condition that impairs their ability to show up. They miss a session, or they have a session that becomes passive because they're too flared up in pain for whatever the reasons are. Other reasons could be financial restrictions, transportation issues, scheduling difficulties. All of these things need to be discussed, kept in an open communication chain. There's nothing I like less than following up with someone after 8 sessions and not seeing any progress. So we want to be successful, and we want you to be successful, but we have to address all these individual issues to see that success. None of us want to see failure. So general issues that may limit progress. So some of the things we already mentioned about being a complicated patient, if that's the case, you have comorbidities, that can limit progress. But as long as it's being discussed and it's understood, you can continue to work around that. Some of the things that need to be avoided, and this not so easy to avoid, is underdosing. A patient comes in, you define them as highly reactive, meaning you give them an activity that you think is gentle, they think is gentle, and then 3 days later, and they're in a lot of pain. And you're like, wow, I wasn't expecting that. That's a highly reactive patient. So now you start to be very gentle with the patient, and 10 weeks goes by, and are you expecting to see results with the low intensity that you're working at? So sometimes you need to adjust. If that's what the patient can tolerate, it's better that they're doing something than nothing. But would we consider that to be rehabilitation or maintenance care? So there's differences there, because that's a different set of goals. My goals is to maintain my body, maintain your current level of function while you're having other more serious medical conditions addressed by physicians, like cardiac issues or gastric issues. And we have you in a maintenance plan. That's different, right? So at least we'd be on the same page with what we're doing as rehabilitation professionals, right? So underdosing is an issue, but we may underdose specifically when we're in a maintenance plan. We might just want to avoid that flare line because there's too many other things going on. We don't want to add musculoskeletal pain to the issue. So when people get their medical needs taken care of and reach a good, healthier medical baseline, then you could start pushing the rehabilitation objectives and prioritizing them a little bit more. One of the things to mention is about accepting the report the patient gives. As a provider, sometimes people will say something to me and it doesn't make sense to me. I'll do a specific exercise for a specific muscle group, and then the complaint 2 days later is that a different muscle group was hurting from the exercise that wasn't what we call the primary mover. It wasn't the agonist. It wasn't the muscle that was doing the work. And, based on my education, I might think like, well, that doesn't make any sense. So do I question the patient's judgment, or just do I accept it and then work around it? And I have found that accepting what the patient says and working around it is the best way to work. Often later in time, it's the reason for the issue comes to light. As we get further down the rehabilitation pathway, a little further down the road, and we get to learn somebody's body better, about how they react to different things and how their muscle synergies were working, or they were co-contracting too much. And even though it didn't make sense to me at the time, it was true and it was accurate, right? The patient's report, even though it didn't make sense at the time. So accept your patient's report and keep working around it as best you can. Now, in my training, I've been trained in doing manual therapies, and I do manual therapies, which is like hands-on healing work with people, myofascial release and massage and trigger point release and joint mobilizations to alleviate pain and to facilitate mobility in the body. But my favorite part of my job is exercise prescription. It's something I enjoy. I find it challenging. It's challenging to be successful at exercise prescription with people who have multiple body parts that are impaired. Sometimes some specialized equipment comes in helpful, some Pilates-based rehabilitation equipment, but mostly it's just having a creative mind and thinking about how can you stabilize one body part as needed, stabilize the joint, and still work the muscle groups. Identifying triggers and getting someone in a healthy routine and teaching them to scale down or scale up based on how they're feeling that day, and perform self-assessments on their low back, their neck, their whole body, if that's the case, and then to move on from there. Some of the most basic generic exercises always follow the tenet of proximal control. Proximal stability enables distal mobility. So mostly starting with the spine, spinal stability and branching outwards. Pelvic control, so important to focus on little minutia of pelvic control, the awareness of the transverse abdominis muscles, the abdominal corset muscles, being able to engage them, learning to know when you're bracing versus hollowing, and little details like that helps you with facilitating your own movement progression. Patients with hypermobility should understand what isometrics are, which isometrics means lack of motion with a muscle contraction, and also about intensity there. High intensity static muscle contractions may not be the best thing for a tendon with hypermobility. So we'll try to modify that a little bit to customize it to someone's tolerance or how they present. The most important thing about making progress is developing a realistic training regimen. As I mentioned previously, the research gives us training protocols that have been proven to work under, controlled clinical conditions. So we already know that a lot of people with hypermobility spectrum disorder, hypermobile EDS, have other medical problems. It makes it more difficult for them to stick to these training regimens because of other medical issues, because of flare-ups. So we always have to adapt these. But keep in mind that overall, anyone will be more successful if they can stick to a program. Understand the concept of building strength, that it takes time. Might change a little bit with age. As we get a little older, it might take a little longer. But regardless of being hypermobile people can increase their strength. They can increase their stability. There's a lot of factors there, of course, need to be individualized. But a strict training regimen is paramount to success. In my practice, I've worked with many people who I consider and would be considered under objective measures as severely impaired. Great difficulty walking, very poor sitting tolerance, not much of a tolerance for functional activities or going out in the community and participating in society. One of the keys is identifying a wellness practice, the keys to success, and not to underestimate simple exercises like Joseph Pilates was a great proponent of practicing posture and breathing. Sounds too simple, but there's a lot of different breathing regimens, breathing exercises in yoga. The movements in Pilates often are associated with different type of breathing patterns. I personally was educated in breathing patterns with some novice martial arts that I learned. Very important to incorporate breathing with your movement. And don't underestimate how even exercising by sitting in a correct posture and practicing your breathing a few minutes a day can impact your life, have a positive impact and positive change on your structure and function, and maybe even clear your mind. As always, I am grateful to be part of this team at New York Institute of Technology. Dr. Riley is a great leader. I have tremendous partners here as physicians and our staff and our coordinator and everyone who helps run this program with the goal of improving people's lives who are dealing with hypermobile EDS, hypermobility spectrum disorder. So thank you to all my coworkers, physicians, and Dr. Riley.
Hi, it is my pleasure to introduce to you Dr. Todd Cohen. Dr. Todd Cohen is a distinguished professor of medicine at the New York Institute of Technology's College of Osteopathic Medicine. He is an educator, a serial entrepreneur. He is an innovator and an inventor. We are so honored to have him. He was trained at Johns Hopkins as well as Stanford, and then finally did his fellowship at UCSF. He is an inventor who holds over 40 patents in different cardiology and robotics inventions. He has also held numerous publications, including in prestigious journals such as the Journal of the American Medical Association and the Journal of the American College of Cardiology. Dr. Cohen has worked closely with our EDS hypermobility team, has been actively involved since his inception at NYIT-COM, and we're so honored to have him as an honored speaker again this year.
Hi, I'm Todd Cohen, and I am here today for the EDS Symposium 2025. Let me share my screen with you, and I will begin my presentation. So today I'm going to talk about the cardiac manifestations of Ehlers-Danlos syndrome. First, I'd like to thank our symposium director, Dr. Bernadette Riley, who's been doing this for a while, and our great multidisciplinary team. New York Tech is an inspiring place, and in particular, our faculty is very accessible, collaborative, and enthusiastic. And our students are eager to learn. So Ehlers-Danlos syndrome is a connective tissue disorder. Many of our patients exhibit this hypermobility that you see on the screen. We can quantify this with a Biden score, but these are some of the things we see in our patients very often. Ehlers-Danlos itself is complicated. It is associated with morbidities, and in particular, I'm focused in on the cardiac morbidities, and specifically the ones that relate to the heart and heart rhythm problems. And a lot of times these patients have a condition called POTS. People come to me with EDS and POTS. POTS is postural orthostatic tachycardia syndrome. These other comorbidities, such as mast cell, gastroparesis, tethered cord, Chiari malformation, may be seen and may play a role. There are common patient characteristics in our population. Most of them are female. Most of them tend to be young and middle-aged, and some of them present with presyncope and syncope, and that's how I get involved. They may also complain of palpitations and pain. We often will see the patients do a physical examination and look at their electrocardiogram, and we're often going to find things such as sinus rhythm and sinus tachycardia. And occasionally we'll see some prolongation in their QT interval or a short PR interval on their ECG. The most common type of Ehlers-Danlos syndrome is the hypermobile type. And we list the different types here. And this is why we often want genetic testing to be done to rule out a known gene. And we see patients with vascular EDS, classic and classic-like EDS. Those are much less common than the most common type of hypermobile EDS. The hypermobile type does not have a known gene. And as I said, we usually start with a history, a physical examination. We will often get the records from their primary care doctor or Dr. Riley if they're referred by Dr. Riley, and we'll do an EKG, a simple test that tells us so much about the patient's heart. We would want in patients with Ehlers-Danlos to have at least had an echocardiogram. And in particular, we're looking for two things. We're looking for dilation in the aortic root and the aorta. And we're also looking for the prevalence of mitral valve prolapse. Sometimes we find other things as part of the standard examination, but those two abnormalities tend to be more common in those with Ehlers-Danlos syndrome. So here's a diagram that tells you a little bit about those two things. On the left, you can see a normal heart, and then you see what happens to the mitral valve where it prolapses upon contraction. Sometimes they can have some leakage of flow of the valve, which we call mitral regurgitation. In addition, we evaluate the size of the aortic root and the aorta, and that we want to make sure they don't have aortic root dilation or an aortic aneurysm. So I talk about the three Ps because I found a relationship in our research related to patients with Ehlers-Danlos syndrome. And the three Ps stand for pain, which they often have from their joint hypermobility, palpitations, which they might have, which may relate to an increased sympathetic nervous system, and POTS, which is postural orthostatic tachycardia syndrome. Sometimes they also have a chest pain, but it is very rare that it is related to coronary artery disease. This slide shows The Last Supper, a wonderful painting that if you ever visit Milan, you should make sure you see The Last Supper. So let's talk about pain. We ask the patients about this. We often ask them to evaluate their pain on a scale from 1 to 10, and certainly most of our patients do complain of pain with Ehlers-Danlos syndrome. Again, the pain itself activates the autonomic nervous system, and there is a response, and it tends to be a heightened autonomic nervous system. The palpitations is the perception of the heart's beating, and oftentimes it may be beating fast in a normal rhythm from the sinus, which is sinus node where the rhythm begins. And when it beats fast, we use the term sinus tachycardia. So if you hear that term, it's pretty common in patients who have Ehlers-Danlos syndrome, and specifically those who have POTS. We like to do things non-invasively. It's kind of an osteopathic tenet where we want to do less invasive unless we really have a need to do something invasive. So we often will start with a very minimal external monitor system. We use this Barty DX system, which is unbelievable in its ability to diagnose rhythms, see the atrial activity, and it's very comfortable for both men and women because it is placed on the chest bone, and they can wear it for 2 weeks and they mail it in. So it's very user friendly, very inexpensive, and easy for us to get information about the heart's rhythm and what's happening. Well, we see one type of POTS to the left, and that's not the kind of POTS we're talking about. This is the kind by AI Weiwei, the Chinese dissident, very well-known artist that I am very fond of. But the POTS we're talking about is the POTS of postural orthostatic tachycardia syndrome. And some of these people occasionally wind up fainting, like in this Boily painting that you see. And yes, this patient could have POTS, but it could be other things. And that's why we may do some testing to determine what this patient truly has. So, what you have to realize is to stay upright, the body has a nervous system, and it's shown here specifically the autonomic nervous system with the parasympathetic on the left and the sympathetic on the right, all coming down from the brain, and it innervates the heart and the blood vessels and helps keep us in balance. Now, there's two systems, the autonomic nervous system, the sympathetic and parasympathetic are in balance, but sometimes they can go out of whack. And that's why they use the term dysautonomia or abnormal autonomic nervous system. We often, but not always, will do a tilt table test. It is not a tilt-a-whirl. It is a simple test, and it only tilts because you're strapped to the table, and it makes sure the patient can stay upright, and then if they're getting lightheaded or dizzy, we can put them down. And this is just an example of the tilt table test, and it's useful for diagnosing POTS, which we specifically look for a heart rate of 30 beats per minute increase when we stand them up from going from lying down to standing up. The heart rate goes up by 30 beats per minute or more over a 10-minute period. We separate that from orthostatic hypotension, which tends to be an increase in heart rate that is abrupt immediately and a decrease in blood pressure. And that is very different from vasovagal syncope or notocardiogenic syncope. Sometimes patients have more than one type that is operative, and we can diagnose that as well. Well, here am I during COVID. We dealt with patients with EDS and helped them through the COVID pandemic. And we found that their POTS symptoms definitely increased. If they had POTS, it got worse. If they didn't have POTS, they probably got POTS. So the answer is EDS is no laughing matter. So how do we treat it? We don't take candy. We use real therapies, homeopathic therapies, such as salting and electrolyte solutions, Gatorade and Powerade I recommend, and chicken soups to keep the vascular status engaged with electrolytes. I like compression stockings, especially high compression stockings, but some people may prefer abdominal binding if they can't tolerate this because of their joint pain. And this is one of our patients who is nice enough to let us tell the audience that what do we need to do? We need to stay salty. We need to make sure their blood pressure is okay, they're staying hydrated, and they're wearing support stockings. And yes, we do give medications for patients who need it. Specifically, again, my general principle, again, it goes to the osteopathic principle of less invasive is better. So what we do here is we start with no medicines first, but if they need medicines, the first line medicine I tend to like is beta blockers because it will specifically help those with POTS, postural orthostatic tachycardia syndrome. There are other medications that can be helpful, but they usually have other side effects that are harder to tolerate. And specifically, I'm talking about the steroid of Florinef or fludrohydrocortisone, and we're also talking about midodrine or proamine, which can increase your blood pressure and help prevent syncope. Rarely invasive testing is needed. This is if patients have other types of rhythm problems, such as SVTs, which just pervade the normal population of people, let alone those with EDS or hypermobility. If patients with EDS undergo this testing, we often have found inappropriate sinus tachycardia, enhanced AV nodal conduction, and rarely SVT. And yes, some patients have needed ablation when they have this, but the incidence of SVT alone, not including sinus tachycardia, is probably comparable to the normal population. And if they have this invasive procedure, they're asleep, they're made comfortable, and then we can map and find their problem and treat it with a procedure called ablation, where we use radiofrequency energy or pulse field ablation to treat the heart rhythm abnormality. And here on the right side, you see one, the patient's totally asleep, does not feel any pain or discomfort. They're monitored typically by an anesthesiologist. We've talked about this multidisciplinary team. Dr. Riley has expounded on this multidisciplinary team, and we have this wonderful team of sports medicine doctors, rehab and physical therapy doctors, pain doctors, you name it, orthopedists, gastroenterologists, and cardiology, as well as the psychological aspect. And we all work together because you have to remember there is no I in team. It is a true team. So here's our fearless leader, Dr. Riley. She has the best EDS program in the country, and I can say that unequivocally. There is access to helpful specialists across the board, and Dr. Riley is really taking EDS patients and their treatment to a new level with our goal of making these patients as healthy as they can be so they can lead as active and as normal a life as anyone else. And again, cardiology is blossoming as it helps EDS. And here we see Dr. Zweibel, our clinical director, and one of our students who had an interest is now a doctor, and Dr. Riley and myself, and we want to thank you.
Thank you for attending our NYIT EDS Hypermobility Spectrum Patient and Provider Symposium. We look forward to seeing you next year.